distinguished colleagues, members of the Egyptian National Stroke Network, and honored international guests, Sirulana Sinavam, it is a profound privilege to stand before you at this inaugural conference, which I believe will be remembered as a turning point in the history of stroke care in Egypt and across our entire region. My name is Osama Yassin Mansour from the Stroke and Neurointervention Center at Alexandria University. I am presenting today on behalf of the MENA-SINO group per the Middle East and North Africa Stroke and Interventional Neurotherapies Organization, MENAS, whose work has produced 2 landmark publications that are the foundation of everything I will share with you today. The first is the MENA-adapted Guidelines for Acute Ischemic Stroke Management, published in Neurological Research, NCS. 2. A comprehensive, evidence-based, regionally adapted roadmap for every aspect of ischemic stroke care. The second is the MENA-adapted Guidelines for Aneurysmal Subarachnoid Hemorrhage Management, published in the Journal of Vascular and Interventional Neurology, CESTI 18.SO, the first regional consensus guidelines for this feared and neglected emergency. And underpinning both of these, I will share data from our own GIS analysis of stroke care geography across Egypt's 27 governorates. 2. A study that for the first time quantifies exactly where the access crisis is, how many Egyptians it affects, and what a targeted hub and spoke expansion achieve. We have 15 minutes together. Let me make every one of them count. Let me give you a roadmap for how these 15 minutes will unfold so you can follow the thread of argument I am building. We begin with the burden, Cerero, not as abstract statistics but as a statement of why this conference, this network, and this moment matter. Then I will take you through the methodology behind the MENA-SINO guidelines, because the scientific rigor of how these guidelines were built is what gives them their authority. From there, we move to the 10 cornerstone concepts for acute ischemic stroke, the clinical heart of the guidelines, ZENO, with special attention to the reperfusion algorithm and the pre-hospital chain, which are the areas of greatest practical impact. The 4th section brings in our GIS study data, mapping Egypt's stroke access crisis in granular, governorate-level detail, Seruman.conco, and showing precisely what a hub-and-spoke network expansion would achieve. We then cover the ASAH guidelines, which address a second major gap in Egyptian stroke care, before closing with resource stratification in practice, the cultural integration framework, and a concrete 3-phase call to action for this network. I will close with 5 additional slides that I hope will move you, not just inform you, Nina, because this work ultimately comes down to real patients in real places who deserve better care than the system currently provides them. Let us begin. This presentation outlines an implementation plan for translating MENA-adapted stroke guidelines into Egyptian healthcare practice. The plan is derived from and grounded in 3 recent publications from the MENA Stroke and Interventional Neurology Organization by the MENA-adapted Guidelines for Acute Ischemic Stroke Management, the MENA-adapted Guidelines for Aneurysmal Subarachnoid Hemorrhage, and the Geographic Accessibility to Acute Stroke Care in Egypt, a population-level GIS analysis with hub and spoke network optimization, which was in press at the time this lecture was recorded. Let me start with the burden. Not the global burden, want our burden. Egypt's burden. The stroke incidence in Egypt is approximately 963 per 100,000 people. To put that in context, that is among the highest documented rates in the world. 75% of all stroke deaths and 81% of all stroke-related disability-adjusted life years occur in low and middle-income countries like ours. This is not a disease of wealthy nations that we are watching from a distance. Nizi, it is destroying families in our hospitals every single day. What makes this particularly urgent in the MENA context is the age profile. The mean age of stroke in Egypt is 58 to 62 years, a full decade younger than in Western Europe or North America. These are breadwinners. These are parents of young children. These are teachers and farmers and civil servants in the prime of their productive lives. And yet, fewer than 1% of eligible patients in Egypt receive intravenous thrombolysis. Fewer than 0.5% receive mechanical thrombectomy. in a country of 108 million people. Why? The reasons are structural, not clinical. Look at the bottom of this slide. 85% of Egypt's neurosurgical beds are concentrated in just 3 cities, forcing rural patients to travel over 200 kilometers with transport delays that routinely exceed 6 to 12 hours. Out-of-pocket treatment costs range from $2,500 to $45,000 in a country where health insurance covers only 10 to 35% of the population. And across the broader MENA region, 17 million refugees face treatment delays that are on average 3.2 times longer than host populations. This is the scale of the problem we are here to solve. And the good news, Cerebral, the reason this conference exists, Noble, is that the tools to solve it are now in our hands. Before we dive into the clinical recommendations, I want to spend a moment on the methodology behind these guidelines, CERUS literate, because the rigor of the process is what earns them authority and ultimately determines whether clinicians and policymakers will trust them enough to implement them. The MENA-SINO framework followed a structured 7-step process. Step 1 was a comprehensive systematic review of every major international guideline, AHA/ASA 2023, the European Stroke Organization 2021 through 2023, NICE from the United Kingdom, the Neurocritical Care Society, and the Chinese guidelines of MENA-laws. Because China's experience with resource-limited stroke care is directly relevant to parts of our region. Step 2 was a targeted search for MENA-specific publications. The team identified 186 MENA-specific publications and unpublished datasets from regional centers of excellence. This is not a small number. Cerebral, it represents a substantial body of regional evidence that previous Western-derived guidelines simply did not incorporate. Step 3 and 4 involved forming a multidisciplinary expert panel of 45 specialists from 22 MENA countries, thus ensuring representation from neurosurgery, interventional neuroradiology, neurocritical care, vascular neurology, rehabilitation, and research methodology, MENA, and running a modified Delphi consensus process. 3 structured rounds achieved greater than 85% agreement on every final recommendation. Critically, every recommendation is tagged with one of 3 designations that you will see throughout the clinical sections. The RL tag, Resource Limited, indicates a specific adaptation for settings where optimal care is unavailable. The EO tag, Expert Opinion, EU, marks recommendations where MENA-specific evidence was limited but consensus was achieved. And the CG tag addresses conflict zones and geopolitically complex settings. This is not a set of guidelines produced in a Western institution and translated into Arabic. It is a genuinely regional product built by regional expertise for regional realities. The AIS guidelines organize their recommendations around 10 cornerstone concepts, a framework that moves from systems-level access all the way through to long-term rehabilitation. Let me give you a brief orientation to all 10, and then we will drill down into the 3 that are most immediately actionable for this network. Corner 1 is healthcare system access. Specifically the recommendation to build regional telemedicine networks that overcome geographic barriers to specialized care. This is tagged RL, meaning it is not a luxury recommendation for high-resource settings. Seriously, it is the primary strategy for limited resource settings. Corners 2 and 3 address rapid reperfusion and resource-stratified care, the clinical engine of the guidelines, which I will cover in detail on the next slide. Corner 4 is cultural integration, our known Arabic fast campaigns, gender-sensitive care pathways, family-centered communication. In Egypt, where 45% of stroke patients in some regions first consult traditional healers before seeking hospital care, this is not peripheral to clinical care. Wombolo Essesin, it is the front door. Wombolo Tomo Senilo Essesin, it is the front door. Corners 5 through 10 address secondary prevention, quality monitoring, workforce development, technology integration, emergency systems, and sustainable implementation. Of these, I want to flag 3 as the highest priority calls to action for this network today: hub and spoke access infrastructure, ZENA. because our GIS data shows this is the single greatest lever for reducing the treatment gap, rapid reperfusion with the drip and ship model. Because our spoke, hospitals can implement this within existing resources, and resource-stratified care was who, because the three-tier framework means no Egyptian hospital at any resource level has an excuse for not delivering evidence-based stroke care. Every patient presenting with acute stroke symptoms undergoes non-contrast CT and CT angiography at the spoke hospital. The pivotal question is, Norasan Lados Adelenius, is there a large vessel occlusion? No LVO or distal/medium vessel occlusion, intravenous thrombolysis with tenecteplase within 4.5 hours if eligible. Routine mechanical thrombectomy for medium vessel occlusions is not recommended, with the distal trial and memento registry provide definitive level A evidence that EVT adds no functional benefit and increases hemorrhage risk. Preserve catheterization laboratory capacity for patients who will clearly benefit. LVO confirmed, the algorithm branches by subtype. Standard anterior circulation, LVO, within 4.5 hours tenecteplase as a bridge, then immediate transfer for EVT. Single bolus administration is a specific advantage for drip and ship, SOMD 10T1 injection, then transfer, no infusion pump required. Large core infarction, cardiovascular 5 Delafif, go directly to EVT within 24 hours. Do not give bridging IVT tobutulonum racinoanal meta-analyses show no added benefit, and it wastes expensive thrombolytic agents. Basilar artery occlusion, the highest priority transfer in stroke medicine. The Veritas meta-analysis, Attention and BioChe trials confirm EVT within 24 hours dramatically reduces mortality and severe disability. Medical management alone carries mortality exceeding 80%. Activate air transport if available. The drip and ship model is the operational spine of the entire system, cerebral cornea, and the hub and spoke network is built around it. Egypt's pre-hospital chain is where the most time is lost, Condyldianus, and where the greatest opportunity lies. Average onset to alarm time in Egyptian registry data is 34 minutes. Alarm to dispatch adds 25 minutes. On-scene time 21 minutes. Door to needle 30 minutes. That is 110 minutes of non-transport time before the patient begins moving toward definitive treatment INONA, and these figures are from our best academic centers. Recognition, BE FAST, is the foundation. The MENA guidelines go further, calling for Arabic translation with visual aids for low literacy populations, pictographic campaigns, radio messaging in local dialects, and engagement with mosques and community leaders. Triage in Cairo, Alexandria, and other major cities. Distance does not equal time. Seri Antomian 8 kilometers can mean 45 minutes in peak traffic. The guidelines recommend real-time GPS traffic data to determine whether a patient goes to the nearest IVT-capable spoke or directly to a thrombectomy hub. Rural settings, community health workers already exist within Egypt's primary healthcare network. A brief standardized training module enables them to recognize stroke, call for ambulance, and notify the receiving hospital, so effectively creating a first responder layer without building new infrastructure. In areas without functioning EMS, partnerships with humanitarian organizations such as the ICRC are explicitly supported. Every minute counts. Every link in this chain is an intervention point. This network is the mechanism for strengthening all of them simultaneously. This slide is perhaps the single most practically useful output of the entire MENA-SINO guidelines process, TWOTCOM, the three-tier resource stratification framework. I want every clinician and administrator in this room to understand it, because it is what transforms aspirational guidelines into executable protocols at every level of the Egyptian healthcare system. The framework recognizes 3 resource tiers. Tier 3 basic resources represents a district general hospital with a non-contrast CT scanner, basic laboratory capability, and neurological assessment capability. Tier 2 intermediate resources unit is a regional hospital with CT angiography, teleradiology access, and a structured stroke unit. Tier 1 Comprehensive Resources (NENAS) is a fully equipped academic or tertiary center with 24/7 neuroradiology, biplane angiography, and dedicated neurocritical care. Now look at what each tier can actually do. For imaging, a Tier 3 center uses non-contrast CT for hemorrhage exclusion and lumbar puncture if CT is unavailable. It cannot do everything, cerebromia, but it can do enough to initiate the clinical pathway and make the transfer decision. Critically, the guidelines are explicit that NCCT combined with clinical assessment is sufficient to begin IVT in most patients. For reperfusion therapy, a Tier 3 center can administer oral tenecteplase, single bolus, no infusion pump, no complex monitoring, warolzineona, and activate the transfer pathway. This is achievable at virtually every Egyptian district hospital that currently has a CT scanner. For secondary prevention, even at Tier 3, aspirin plus generic clopidogrel, a generic ACE inhibitor and thiazide diuretic, and structured lifestyle counseling are all evidence-based, cost-effective, and available. The key message I want you to take from this slide is this: there is no resource level at which doing nothing is acceptable. The guidelines define what good care looks like at every tier. A basic center that gives tenecteplase, performs a structured clinical assessment, and initiates a transfer to a hub is not a suboptimal center, cum laude. It is a center delivering evidence-based care at its appropriate tier. That is what this network needs to recognize, to certify, and to support. I want to turn now to the second publication, the MENA-adapted guidelines for aneurysmal subarachnoid hemorrhage, published in the Journal of Vascular and Interventional Neurology. This is genuinely new territory, MANA. Until this publication, there were no regional consensus guidelines for ASAH management anywhere in the developing world. Why does this matter? Because aneurysmal subarachnoid hemorrhage is one of the most feared and treacherous neurological emergencies, with a mortality impact that is profoundly sensitive to the quality of specialized care. In high-resource MENA centers, in-hospital mortality ranges from 12 to 18% or comparable to international benchmarks. But in limited resource settings across the region, mortality ranges from 28 to 35%. That 15 to 20 percentage point gap represents preventable deaths to patients who could be saved with the right protocols, the right equipment, and the right training. The epidemiology in MENA is also distinctive. The mean age at our such presentation is 45 to 50 years in MENA populations, plus younger than in Western cohorts. Incidence data from Turkey, Egypt, and Saudi Arabia range from 3.8 to 5.7 per 100,000. And in a 2022 regional survey, only 42% of hospitals treating ASAH had dedicated neurocritical care capabilities. The 10 cornerstone concepts for ASAH mirror the AIS framework in structure. Let me highlight the 4 that are most directly applicable to Egyptian practice. Cornerstone 1, Healthcare Access, the recommendation for regional telemedicine networks to support ASAH consultation and image interpretation at centers without 24/7 neuroradiological expertise. Cornerstone 4, Medical Complications, standardized ICU care bundles adapted for varying resource availability. Because the majority of preventable ASAH deaths occur from complications, not from the bleed itself. Cornerstone 6, DCI monitoring, training nurses to perform standardized neurological assessments for the detection of delayed cerebral ischemia, the most important complication of ASAH, occurring in 30% of patients between days 4 and 14. And Cornerstone 9, cerebrovascular imaging, individualized follow-up protocols based on risk stratification and local resource availability with teleradiology support for interpretation. These guidelines give Egyptian neurovascular centers for the first time a regionally validated framework for the entire ASAH care pathway. The GIS study, UNFLO, the first population-level, modality-specific analysis of stroke care access across all 27 Egyptian governorates, CIAFLO, makes the case more powerfully than any guideline. Methodology: we verified 29 IVT-capable hospitals and 13 MT-ready centers, mapped 120 settlements covering 89.3% of Egypt's population, 108.3 million people, and calculated onset to treatment times using a validated routing algorithm accounting for terrain, traffic, Nile crossings, and local registry data. Key findings: 71.8% of Egyptians have optimal IVT access, linear, but only 56.2% have optimal MT access. 22.1 million Egyptians have zero MT access within the 6-hour window. A population larger than the Netherlands, 9 of 13 MT-ready centers are concentrated in Cairo and Giza, serving just 19.2% of national population. A single center, Asyut University Hospital, serves all 27.3 million Upper Egypt residents, performing only 13 procedures annually. 44.2% of Upper Egypt residents are MT eligible with no transfer pathway. Minya's 6.3 million, Sohag's 5.7 million, Beni Suef's 3.6 million are not ineligible patients. They are infrastructure abandoned patients. The proposed deployment, with 3 new MT hubs and 4 IVT spoke upgrades, improves MT access from 56.2% to 75.8%, cutting the MT denied population from 22.1 to 8.6 million, minus a 61% reduction. At the Tier 3 spoke, critically, only spokes with a 64-slice CTA-capable scanner can participate in the MT transfer pathway. This is a non-negotiable infrastructure requirement. The GIS model identifies 3 priority MT hub locations: Aswan University Hospital grad from IVT only, serving Aswan, China, and Luxor. Minya University Hospital, new build serving Minya and Beni Suef, 9.9 million people currently without any MT pathway, and Port Said Teaching Hospital, new build serving the Canal Zone and Northern Sinai. 4 spokes, Sohag, China, Luxor, and Al Arish, require 64-slice scanner upgrades. Total capital investment $16.02 m. Annual operating costs $4.65 m. Projected impact: 240 additional IVT treatments and 120 MT procedures per year, yielding -206 QALYs annually. Base case ISA $15,400 per QALY, with a 73.2% probability of cost effectiveness at Egypt's 3-year GDP threshold. This is a costed, optimized, evidence-based plan. Effective guideline implementation in Egypt requires confronting 2 realities. Western models rarely address the cultural dimensions of medical decision-making, and Egypt's distinct secondary prevention risk factor landscape. Cultural considerations in MENA societies: the family, Leron Lela, Omula, not the individual. Lela is the primary medical decision-maker. Clinicians must communicate with multiple family members simultaneously, not seek a single designee as Western models prescribe. For poor prognosis ASAH, teams must navigate end-of-life discussions with both clinical honesty and sensitivity to Islamic traditions. Female patients in some communities face access barriers without a male guardian present, requiring gender-sensitive pathways and available female providers. Avlorelina delays here are directly clinical. Critically, data from Morocco and Jordan show 45% of stroke patients consulted a traditional healer first, causing 4 more 6-hour delays. Community stroke champion programs, training imams, teachers, and community health workers seen are the strongest evidence-based mechanism to address this. Secondary prevention: Egypt's risk factor profile demands tailored strategies. Hypertension affects 26 mil 38% of MENA adults. The Progress trial supports generic perindopril plus indapamide as a Class 1A recommendation. Intracranial atherosclerotic disease is significantly more prevalent here than in Western cohorts, making the Sampris-derived aspirin plus clopidogrel regimen for 90 days especially important. Finally, Egypt's high H. pylori prevalence makes routine proton pump inhibitor co-prescription essential when initiating dual antiplatelet therapy. I need to pause the data for a moment, because I want to talk about who we are actually here for. Ahmed is 54 years old. He is a farmer in Minya, Selo, a father, probably a grandfather. He wakes at 6 in the morning with sudden left arm weakness and slurred speech. His family calls for help. The nearest hospital has no CT scanner. The nearest MT center is 330 minutes away. Under the current system, Ahmed is denied mechanical thrombectomy, not because his brain does not need it, not because he would not benefit from it, but because the infrastructure has simply never been built in his part of Egypt. Under the proposed MENA hub, a hub that our GIS model shows is achievable for $3 million, Sero Ahmed reaches treatment in 95 minutes. He goes home to his family. Fatima is 47. She is a school teacher in Sohag, with a classroom of children who depend on her. When she develops sudden speech difficulty and right-sided weakness, her family does what millions of Egyptian families do, quote, they wait, they consult the local healer, they seek reassurance before seeking medicine. By the time someone recognizes the urgency and calls for an ambulance, 4 hours have passed. By the time she reaches Cairo, the treatment window has closed. This is not a failure of medicine. It is a failure of community education. A trained stroke champion in her neighborhood, Bessa Munal, following the MENA guidelines recommendation Hazima, would have recognized BE fast and called immediately. The window would have been open. Ibrahim is 62. He is a civil servant in Port Said. He develops the sudden onset of dizziness, dysarthria, and altered consciousness or basilar artery occlusion. Without treatment, the natural history is 80% mortality or severe disability. The nearest MT center is in Cairo, more than 3 hours away. But the Port Said hub that our GIS model identifies as the third priority investment, Ibrahim is treated. He walks out of hospital. These are not hypothetical patients. They are the statistical reality of what is happening in Egypt every single day. And what I am asking of this network is that we refuse to accept these outcomes as inevitable, because they are not inevitable. They are a choice about whether we build the infrastructure, train the workforce, and implement the protocols that could save them. Phase 1, Year 1, Standardization and Data, formally adopt MENA-SINO guidelines as the national clinical standard, endorsed by the Ministry of Health replicate GIS mapping nationally, creating a live stroke infrastructure database, launch an Arabic BE fast campaign across all governorates through ministry channels, establish a structured telestroke network connecting all 13 MT hubs with 29 IVT spokes, set as years with defined protocols and data collection. Not informal image sharing, implement a national stroke registry tracking onset to door to needle, door to groin, and 90-day MRS outcomes. Phase 2, Years 1-3, Infrastructure, build or upgrade the 3 GIS optimized MT hubs, AS1, Minya, Port Said, upgrade 4 IVT spokes with 64 slice CTA capable scanners, train 1,350 community stroke champions, R50 per governorate mean. Within 2 years, launch RSSAH management pathways at all Tier 1 neurovascular centers. Phase 3, Years 3-5, coverage and sustainability, expand telemedicine to all 27 governorates, including frontier areas, establish a stroke center accreditation system based on MENA-SINO standards, advocate for tenectoplaces inclusion on the National Essential Medicines list, single regulatory action that would expand thrombolysis access at every district hospital in Egypt. Every item is evidence-based, costed, and achievable within existing health system structures. What it requires is the leadership of the people in this room. Telestroke from informal practice to formal infrastructure. Informal telestroke already exists in Egypt. Colleagues are already sending CT images via WhatsApp and calling mobile phones for advice. This saves lives, but it is fragile, undocumented, and invisible to quality monitoring. The MENA-SINO guidelines recommend formalizing what already exists into a structured, protocol-driven service with defined roles, response time targets, data collection, and integration into the hub and spoke transfer pathway. Egypt's conditions make this uniquely achievable mobile penetration at 97.6%, 4G coverage across 85% of the Nile Valley corridor, and an existing health informatics backbone through the Universal Health Insurance System. The cost of a formal national telestroke platform, WinUS software, training, and hospital integration, WinUS Citadel 9, is approximately $80,000 per year. That is the cost of treating 5 empty patients privately. A rounding error in any hospital budget. The impact is concrete, reducing door-in door-out coordination time at spoke hospitals by just 30 minutes. Seroless, a conservative target, Seroless, moves an additional 4.2 million Egyptians into optimal treatment access. Without a single new facility, without a single new imaging machine. The technology exists, the connectivity exists, the evidence exists. What this network must provide is the protocol, the mandate, and the will to implement it. The single highest return investment this network can make is not a new angiography suite or CT scanner. It is a trained stroke nurse in every Egyptian hospital. Egypt has 1.08 IVT trained physicians per million nationally, was falling to 0.04 per 100,000 in Upper Egypt. Training a neurointerventionalist costs $200,000 and takes 5 to 7 years. Training a stroke nurse to MENA-SENO standard, stroke recognition, NIHSS assessment, IVT checklists, DCI monitoring, family education mini costs $2,000 and takes 6 months. 10 nurses per IVT capable hospital across 29 hospitals gives 290 trained stroke nurses deployed nationally within 1 year. Evidence from Rwanda and Nepal demonstrates that nurse-delivered stroke recognition and IVT initiation protocols significantly reduce door-to-needle times and improve outcomes. Egypt's nurses are better trained and better resourced than those comparators. The immediate deliverable is a single laminated card, BE Fast in Arabic and English on one side, the 4-item NIHS screen, IVT eligibility checklist, and transfer trigger criteria on the other. 50 cents to print. This network can design it, print it, and distribute it to every Egyptian hospital within 3 months. Train the nurse first, build the hub second, because the nurse will be there, delivering care, educating families, triggering transfers long after the ribbon cutting at the new hub has been forgotten. The dominant narrative 40 know that guidelines originate in wealthy countries and are passively received by systems like Egypt's Ondinet. Egyptian centers contributed to the Memento Registry, the most important global validation of mechanical thrombectomy. Egyptian cohort data shaped antiplatelet recommendations for the entire MENA region. The 6-factor routing algorithm developed here is the most sophisticated stroke access model published for any African country. And the corrected Upper Egypt finding reframed a fundamental global question: are treatment access gaps biological or structural? Egypt answered, "Iskrunkia, they are structural." Achieving even 5% IVT treatment rates would make Egypt the highest volume stroke treatment country in Africa and the Arab world. Egyptian registry data will power the next MENA guideline update cycles in 2028 and 2030. Egypt's physicians are on the MENA-SENO author list, ceremonia, not the acknowledgements. That intellectual leadership must now become implementation leadership. I want to close with something different from a summary or a set of recommendations. I want to close with a commitment. Sadul Bolhatta Libyan Zast Enahantila Libyan Saplo, Vajasila Libyan Monte Zaski Pamlamemasa, and I want to ask each of you to make this commitment with me. We pledge that no Egyptian will be denied stroke treatment because of where they were born, not because they live in Aswan instead of Cairo, not because they live in a farming village in Minya instead of a suburb of Alexandria. Geography is not destiny in medicine, vendor, or it should not be. We have the tools to make it otherwise. We pledge that a farmer in Minya and a banker in Cairo will receive the same standard of care, not the same building, not the same equipment, the same evidence-based standard of care adapted to the resources available, Mingumia, because that is precisely what the resource-stratified framework delivers. We pledge that the guidelines built by our colleagues will be implemented by our hands. This is the moment where the work of 45 experts, 3 Delphi rounds, 186 publications, and 2 landmark papers becomes real clinical practice, MENA-adapted, or it doesn't. The difference is the decision each person in this room makes when they go back to their institution on Monday morning. We pledge that the 22 million Egyptians currently denied mechanical thrombectomy will not wait another generation. The GIS model gives us the exact locations. The cost-utility analysis gives us the economic justification. The MENA-SENO guidelines give us the clinical protocols. The Egyptian National Stroke Network gives us the mandate. What remains is the political will. And we pledge Cerula today, in this room, at this inaugural conference, Neurology, that this network is the beginning of that promise. Not the culmination of good intentions. The beginning of measurable, accountable, population-level change. The MENA-SENO guidelines give us the standard. The GIS model gives us the map. This network gives us the mandate. What we do next, Cerulal, for Ahmed in Minya, for Fatima in Sohag, for Ibrahim in Port Said, and for 22 million Egyptians whose names we do not yet know, but whose lives hang on our decisions. Cerulal is a choice. I thank you for your attention, and I look forward to building this network together.